quickly start with the session.
Yes.
Great. So good afternoon, everyone. And today we welcome you for the 12th series on drugs and lymphoma. And today our program director is Dr. Prashant Mehta, sir. So Prashant Mehta, sir, is a senior consultant program head in lymphoid neoplasms and cellular therapy at Department of Hematology and BMT at Amrita Institute, Faridabad. I will quickly go on to introduce our moderator for today, Dr. Lingaraj Nayak, sir, who is a professor of medical oncology and BMT at TMH Mumbai. So I hand over the proceedings to Dr. Lingaraj.
Thank you, Karan. Am I audible?
Very much, sir.
Yes, sir.
Yes,
Yeah,
yes, Dr.
so
Lingaraj. Audible.
thank you. It's a pleasure to be in this platform now with so much enthusiasm amongst the residents and especially Karan. And it's my privilege to be the moderator for this session, which is specifically a lymphoma, which is a topic which is close to my heart because my one of the area of interest is lymphomas. And for residents, I think I'll just give a startup so that we can quickly go to the talk presentation by Faheema. That we have so many developments that is happening in the space of lymphoma, be it immunotherapy, cellular therapies, but your age-old chemotherapy will remain and will remain with you for many years to come, and it is very important for the trainees to be very well equipped with handling basic chemotherapy that you're going to use in lymphomas. And I'm sure Faheema is the expert in kind of bringing all the aspects of drugs together, and we're there to kind of pitch in and kind of take it ahead. So maybe without further ado, I will hand over to Stalin, right? So I will request Dr. Stalin, and Stalin is a dear friend. He's a chief medical oncologist at Mahatma Gandhi Cancer Institute at Visakhapatnam, and Stalin will introduce the speaker for the session today. So over to you, Stalin. Stalin, can you hear us?
Yeah.
Yes, Stalin.
One minute. Yeah. Good afternoon, everyone. So without much waste of time, we go. So I have attended previous E-Gurukul series also, so they're excellent. So the young medical oncologists are doing a fantastic job in educating the residents, and the sessions are going extremely well. So without much waste of time, we go into the topic of today, the drugs in lymphoma. So the today's speaker is Dr. Faheema Hasan. So she is associate professor in the Department of Hematology at United Institute of Medical Sciences, Prayagraj. Faheema, over to you.
Yes, sir. Thank you. Is my screen visible?
Yes, ma'am.
Yes, ma'am. Yes.
And you're audible as well.
Yeah, great. So we'll go ahead. Just like Lingaraj sir said, the chemotherapy is there to stay. But today we'll be focusing on the small molecules and a few protocols which have been missed in the previous session. Most of the chemotherapeutic drugs has been discussed. So we are going to be mostly talking about targeted therapies. So this is a more simplified version of WHO Hematolymphoid 5th edition. It doesn't look simplified at all, but this is the most simplified form we can get. So we are going to further simplify so that we don't miss on any lymphoid neoplasm. So lymphomas, for better understanding, we are going to divide it as Hodgkin and non-Hodgkin, and non-Hodgkin as B and T. So first we'll look at Hodgkin's disease. So what are the protocols currently in use? Nivolumab AVD, BV-AVD, our good old ABVD, escalated BCOP, and BREC-ADB. So we have discussed all the chemotherapies involved. So, and also the nivolumab and pembrolizumab have been discussed in the solid malignancies. So what we are left with is brentuximab vedotin, not the very new kid, but a little newer kid in the block. So what exactly is brentuximab vedotin? What we get to know from the name is that it is a monoclonal antibody, brentuximab part. The fact that it has X says that it's a chimer, just like rituximab, right? So when there's a second part, which is a vedotin part, it is the payload of the brentuximab. So it's a chimeric IgG1, the target being CD30 antigen, and there are three parts for the drug, which is the chimeric IgG1. Then we have a linker, and we have the payload, which is MMAE or monomethyl auristatin E. So the drug binds to the CD30, then it's internalized, then it fuses with the vesicle. So what exactly MMA is? It's a microtubule toxin. So what it's going to do is, it is released in the tumor microenvironment. It causes microtubule damage. So cell cycle arrest followed by apoptotic cell death happens. So this is the mechanism of brentuximab vedotin, or basically the mechanism of action of every antibody drug conjugate. So what is the dose? It's 1.2 milligram per kilogram, 2 weekly with AVD. Elsewhere, it's 1.8 milligram per kilogram, 3 weekly. What are the indications? Now we are looking at Hodgkin's. We'll also come across in PTCLs, anaplastic large cell B-cell lymphoma, CD30 positive DLBCL, not upfront, but in the second time or later. So when do we have to be really cautious with brentuximab? It's in the presence of a liver impairment. So if there is mild to moderate liver impairment, you can reduce the dose to 0.9 milligram. When there is moderate to severe hepatic impairment, it is not recommended. And mild renal impairment, you can go ahead with the full dose. But if creatinine clearance is less than 30, do not consider this drug. So how do you infuse? You pre-medicate with three things: your steroids and your paracetamol and your avil or chlorpheniramine. Okay, and you infuse it over 30 minutes. Unlike rituximab, which we use a longer hours for infusion, you can infuse this over 30 minutes. And as with any chemotherapy or as with any B-cell targeted monoclonal antibody, HBV screening is totally indicated with special reference to brentuximab vedotin, just like that in rituximab. Okay, so, and should we consider GCSF prophylaxis in patients receiving Adcetris? Of course, yes. There can be significant grade 4 cytopenias also. So primary GCSF prophylaxis is recommended with administration. And the most recent FDA approval for BV is in combination with lenalidomide and rituximab for adult patients with relapsed or refractory large B-cell lymphoma. So this is its latest addition on its hat. HBV screening, as I said, should be really considered. Just like rituximab, it can cause HBV reactivation. You can have JC virus infection in the form of PML. You can, as with any monoclonal antibodies, you can have severe hypersensitivity reactions. But what we are well aware of the rest of the side effects. But what should be really concerning is the severe hepatotoxicity associated with brentuximab vedotin. That is a matter of concern. So you should be monitoring the bilirubin as well as the liver enzymes concomitantly after administration. Even at baseline, the patient did not have, it needs to be monitored. Pancreatitis can happen, hyperglycemia can happen, and it is notorious to cause sensory neuropathy. We are also omitting bleomycin in the protocol when we are administering BV, mostly because it can also cause non-infectious pulmonary toxicity. And as a matter of fact, the only contraindication with BV, as per the insert, is concomitant administration with bleomycin. Now, Hodgkin is done. We are going to come back to our non-Hodgkin's lymphoma, the most common of it being DLBCL. So 1975, we found that combination chemotherapy works wonders in large cell lymphomas. And only after 3 decades, we had R-CHOP. And not until another 2 more, we did not know about any newer drugs for this. So R-CHOP has been the standard of care all along. So even now, the first line therapy is R-CHOP, immediately to be followed by Pola RCHP. So all the chemotherapies have been previously discussed. So the only 2 things which has been missed out is rituximab and polatuzumab. So we'll go in depth about rituximab, a beautiful drug, and also Pola, which is appearing pretty attractive in a certain subgroup. As we can see, this is what we are following currently in IPI more than equal to 2. And we are also having newer data in ABC subgroup to go ahead with Pola RCHP. So what is rituximab? Just with the X, we can say it is a chimera. So what is the mechanism of action? As we all know, it is a monoclonal antibody against CD20. What is CD20? It's a transmembrane protein marker. It's a calcium channel expressed on B cells during differentiation from the pre-B cell until the plasma cells. This is the reason why we cannot use rituximab in myeloma, the fact that CD20 is negative in the most mature form of B cell, which is plasma cells. It's a chimeric, where what is a chimera between the murine and the human monoclonal immunoglobulin IgG1 antibody that targets CD20. So how does cell death happens with rituximab? It does not have a drug load. So it is basically the drug itself, the monoclonal antibody itself can cause significant toxicity in the form of ADCC, antibody-dependent cellular cytotoxicity, complement-dependent cytotoxicity, antibody-dependent phagocytosis, and also the direct effects of binding of rituximab to CD20 per se can cause cell lysis. Even though we are talking about rituximab and DLBCL, the very first indication of rituximab came in follicular lymphoma. And it's the first oncological monoclonal antibody that came into practice. So it is a very beautiful drug, which is still being used not only by oncologists, but also by immunologists. And we need to know everything regarding the drug. So what are the warnings when we are giving rituximab? Fatal infusion reactions can occur. Sometimes with different, we are not using the original Rituxan, we are using biosimilars. Some patients may be, having severe hypersensitivity to one brand and not to the other. So the infusion reactions can be so severe that you'll have to discontinue. So you'll have to watch for, especially during the first administration of the drug, watch for fatal infusion reactions. I recommend when your drug is around, 600 milligram or something, the first trial we use 100 milligram vial so that we don't have to use the whole dose or the 500 mg product, which is very, very expensive. It has been, the price is low, but still it's an expensive drug. So be cautious. It can cause severe mucocutaneous reactions, just like how we discussed in brentuximab. We can have PML, reactivation of hepatitis B virus. So the take home of this monoclonal antibody talk alone is that you have to check and screen all patients for HBV infection, not only by hepatitis B surface antigen, but hepatitis B core antibody is also very, very important. So if any patient becomes positive, you need to talk with the hepatitis B expert and plan on prophylaxis. So how do we administer it? Never by IV push. We have the subcutaneous formulation available right now, but we are not routinely using it in our clinics. Pre-medicate with antihistamines, steroids, and paracetamol, and initiate infusion rate at 50 mg per hour. And thereby, there is no reaction. Slowly, you can increase the infusion rates. So viral reactivation is a special mention. Hepatitis B, SAG, and CAB has to be done. And you have to start prophylactic therapy if at all it is positive with entecavir. Most commonly we use entecavir. And PML is also usually fatal, caused by JC virus. And there is no therapy. And the clinical indications may include changes in behavior such as confusion, dizziness, loss of balance. And how do we diagnose this? We had a case recently. We made it by PCR of the CSF. The sad thing is that we could not do much about it. So rituximab is done. Pola will go in depth, but with rituximab, when and how to RDA epoch? So this is a question which I'm commonly asked. Which is the indication for RDA APOCH? Currently, it is only, if we see the pictogram which I shared before, it is currently indicated in double hit or triple hit lymphoma. And we really don't have much of data supporting it, but still, if you have a justification to give DA epoch R in these cases. Why? Based on this Lancet paper, where it was actually single arm phase 2 study, where we saw that with MIC arrangement, there is some benefit for this RDA epoch. So how should we give? This is a protocol. We are all well aware. The problem comes for the fact that we'll have to know how to administer this every 24 hours. In our center, what we do is we mix doxorubicin, vincristine, etoposide together, wrap them in a foil and give it over 24 hours to prevent heat inactivation, or I really don't know the cause. I tried to find out. I could not find any protocol where it suggests. But for the past 2 institutes I have been working, we usually wrap it in an aluminum foil. Lingaraj sir may be able to give us more insight on that. And GCSF should be started daily from day 6 and continue till ANC is more than 5,000. We'll see why. And when we are giving RDA epoch, it does not have a CNS prophylaxis, so we'll have to give it in the form of intrathecal therapy. And we are also giving RDA epoch in adults who are not able to tolerate, intensive chemo regimens like Megrath in Burkitt's lymphomas, and also in primary mediastinal B-cell lymphomas. So this is exactly how we should RDA epoch. And the moment it is stopped, what we should be doing is we should do twice weekly complete blood count, so that the DA stands for dose adjustment. The dose adjustment is going to be based on our absolute neutrophil count. So how do we? So this is the 1 star is a drug dose where we are starting. This is the starting point. So based on the twice weekly CBC we are doing, we are going to dose adjust. Say, for example, the patient is not having any significant cytopenias. We can go for increasing the dose level. Okay. And and if there is a significant cytopenias, we will go decreasing the dose adjustments. So dose adjustment below starting level will apply only to the endoxan, whereas if it's going above the level, it will apply to etoposide, doxorubicin, and cyclophosphamide. So this is something we should be remembering. So now we come to the next drug in the large B-cell lymphomas, polatuzumab, the new kid on the block, the light at the end of the tunnel, whatever we can call the newest drug after so many years of not much of a novel therapy help actually in DLBCL. R-CHOP-X did not cause much of claps for management of DLBCL. But then, yes, polatuzumab showed some benefit, even though not in the OS, but definitely in the PFS side. So what is it? Just like your brentuximab vedotin, this is also polatuzumab vedotin. There is no X, so it's a completely humanized immunoglobulin IgG1 monoclonal antibody. Vedotin is a payload or the drug conjugate, which is going to cause cell lysis. As with brentuximab, what is the cytotoxic load we are giving is again monomethyl auristatin E. So it binds to the cell surface, the antigen being CD79B, and then it's internalized similar to brentuximab vedotin, that it causes apoptosis of the cells. So poly-V. So how do we administer? Just like any monoclonal antibody, we are going to give the 3 pre-medications, which we previously discussed, and the administration is over 90 minutes. So what are the black box we should be seeing? Peripheral neuropathy, infusion-related reactions, severe myelosuppression, serious and opportunistic infections, PML, because these are all targeting our B cells, right? Tumor lysis syndrome, hepatotoxicity because of the vedotin part. So it's similar to brentuximab, but actually Pola CHP has been way better than Benda in my clinical practice. I have given for 2 patients and we did not see any much side effects of polatuzumab. So there are also dose reduction. There are 3 ways how we reduce. The first reduction being brought up to 1.4 milligram and second reduction being 1 milligram per kilogram. And if you're even with 1 milligram per kilogram, if you're having more of grade 3, grade 4 toxicities, there is no reduction beyond 1 milligram per kilogram. So this is something you should notice about polatuzumab. So now we have seen what are the major protocols we use in DLBCL. All the chemotherapies in the relapsed refractory segment have been previously discussed. What has not been discussed is CART, which you have a separate talk on. And we have these 2 kits, epcoritamab, glofitamab, and tafasitamab. Okay, so we'll see a few slides on it. Bispecifics or bispecific T-cell engagers. How do they act? So this is an IgG-like bispecific antibody. It brings your CD3 positive T cells and your tumor cells together and causes redirected tumor lysis and with the help of performin and granzymes. So it's a FC-mediated effector mechanisms. So there are multiple bispecific antibodies. Recent accelerated approvals for epcoritamab and glofitamab. So both of these act via CD20. And Blinat, we already know, you guys have discussed it in the last class, CD19 targeted BiTE. So with BiTE, what we can expect is CRS. So glofitamab is very effective BiTE because it has a unique 2:1 molecular configuration, which allows no double binding to CD20. So you can see this. So it causes double binding to CD20 as it is highlighted in the blue zones. So it causes superior potency in preclinical experimental conditions, and it allows concomitant treatment with anti-CD20 antibodies also. So then we go about the smaller bites. Now I just wanted to share this slide. Like, what are the ways we can target a B cell? So we are already having CD20 CD20 monoclonal antibodies. We have CD19 on B cells where we are using CD19 targeted monoclonal antibody. The slide was so pretty, so it's a very old image. I just had to use this is Staffa MOR 208. And CD79B, you have polatuzumab vedotin, and we have CAR CD19 targeted. We have CD19 targeted ADC, which is loncastuximab tessirin. And we are also having this B cell receptor signaling pathway inhibitors, which are, really novel, and most of them are oral, and we are using it in a array of B cell lymphomas. So we have BTK inhibitors, which was also discussed in the previous class, but then I'll touch upon it a bit, and mTOR and PI3K and SYK. We are mostly going to be dealing with BTK and PI3K with the B cell lymphomas in the next few slides. So this is a B cell receptor pathway where we basically have our PI3K inhibitors and the BTK inhibitors, which are potent B cell receptor pathway inhibitors. Tafasitamab, I think the slide has been up and down. It's a monoclonal tafasitamab, no X. It's a fully humanized CD19 monoclonal antibody. So relapse refractory, Tafalen has come into place. No time to discuss on the protocols, just for a completion purpose. So CLL, we'll come into CLL right now. So whether or not TP53 mutated or not, IGHV is mutated or not, ZAP70 is positive or not, I'm pretty sure most of us are using BTK inhibitors in the first line therapy. Acalabrutinib is a go-to. Even though NCCN divides as TP53 positive and negative, the preferred regimens are still the same. We have acalabrutinib, we have venetoclax plus obinutuzumab, acalabrutinib plus or minus obinutuzumab, and zanubrutinib as the first line therapy in CLL. So this is a timeline showing the evolution of BTK targeting therapies. What exactly are these BTKs? This all happened with the discovery of X-linked agammaglobulinemia by Dr. Ogden Bruton. So there was a lack of expression of BTK due to mutations in this X chromosome. And this BTK is very much essential for maturation of pre-B cells. And extensive molecular and cellular analysis have confirmed the critical role of BTK in multiple hematopoietic signals. And this made us a potential target as a targeted therapy in B cell malignancies. So BTK inhibitors, we'll go in detail. But before that, since I previously also showed you all the upfront therapy talks about BTK inhibitors and venetoclax, is there a role for chemoimmunotherapy as a first line as of now? As Lingaraj sir started, chemotherapy is the backbone of treatment. In CLL, there is a role for FCR, but when? So when we are talking about time-limited therapy, even though venetoclax plus or minus obinutuzumab or even rituximab is time-limited, and patient might not be having so much of funds, or for some reason, he wants a limited 6-month treatment, it still has a role in treatment, provided TP53 is not mutated. In young, fit, IGHV mutated, no deletion 17p or TP53 unmutated patients, you can consider FCR chemotherapy. When can we consider chlorambucil? Older, unfit, IGHV mutated, we are not using it anymore because the novel BTK inhibitors in the form of acalabrutinib has been gentle. Ibrutinib was very toxic, cardiotoxic, but then we are finding acalabrutinib relatively very tolerable. So when financial toxicity is considered, because I am going to be talking about BTK only, there still is a role, but though the role is very limited and the major concern is financial toxicity. So how have been our overall safety experience been with Bruton tyrosine kinase inhibitors? Things which we are worried about is AF, arthralgia, bleeding, of course, infection, hypertension, and diarrhea. So what are the steps we should be taking, whatever the BTK inhibitors be? Do not give it concomitantly with warfarin. If there's a new onset AF, non-warfarin anticoagulation is recommended with monitoring. And if the patient is priorly hypertensive, manage with antihypertensive before you start Acala. Monitor for and manage cardiac arrhythmias and treat appropriately. Monitor patients for signs of bleeding and infections. And acalabrutinib has a higher incidence of headache, so treated with caffeine and paracetamol. Zanubrutinib, not very commonly used currently, is notorious for causing grade 4 neutropenias for first occurrence. Dose interruption is recommended along with GCSF support. So sequencing to second generation BTK is a useful strategy in settings of ibrutinib intolerance. Say, for example, a patient was started on ibrutinib and you were continuing and you are seeing the TLC is raising or the lymph nodes are reappearing. You can always go to second generation BTK inhibitors. So which BTKI when? Any BTKI in the case of no cardiovascular risks. Second generation BTKI in patients with low to intermediate cardiovascular risk, say for example, persistent AF, hypertension, or past history of MI. In patients with high CV risk, do not give BTKI. So we also saw that acalabrutinib plus or minus ibrutinib, plus or minus obinutuzumab was the first protocol given by the NCCN. When should we use an anti-CD20 monoclonal antibody? So the Illuminate and the E1912 studies demonstrate that ibrutinib O between ibrutinib R UMRD, they achieved UMRD with the ibrutinib O combination. It did not clearly show improved PFS. And also, when you're giving ibrutinib with rituximab, it also impairs rituximab mediated ADCC. But addition of obinutuzumab with Acala appeared to improve rates, especially in TP53 aberrant CLL. And also, as you would expect, but when you're adding Gaziva with Acala, there was higher risk of grade 3, grade 4 cytopenias, as you would expect with the second agent. So to add or to not recommended with rituximab, definitely if you can give Gaziva with the PAP, you can go ahead. So I was using this term obinutuzumab. So I also thought, okay, I have to touch upon the 3 available anti-CD20 monoclonal antibodies: rituximab, ofatumumab, obinutuzumab. We don't use ofatumumab anymore. Obinutuzumab is being used in CLL and follicular lymphoma also, while rituximab is a chimera. Obinutuzumab is a fully humanized monoclonal antibody. It is defucosylated and it has a better ADCC, but still, when we had, which R-CHOP versus obinutuzumab compared head on head, there was not much of a benefit. That is the reason we still go with R-CHOP in DLBCL. But yes, in CLL, obinutuzumab has a role. So we have decided on CD20, and we also know ibrutinib, acalabrutinib, and zanubrutinib have better PFS compared to the conventional chemotherapy. And we can use any of these 3 BTK inhibitors. We are not using ibrutinib anymore in the clinical practice because of increased cardiovascular toxicity, which we have seen. And also the price point, acalabrutinib is as cheap or as expensive as ibrutinib. So now we come to venetoclax and obinutuzumab. Venetoclax will be dealt with in detail with your myeloid malignancies. So I'm not going to go into detail with venetoclax. So this is a protocol, obinutuzumab and venetoclax. You have to have a staggering venetoclax dose because of high risk of tumor lysis syndrome. So you will also have to have a sliding scale of starting venetoclax with 20 mg in the first cycle, only introduced after day 22. And even with the second cycle, you go with 50, 100, 200, 400. Does not apply to Indian scenario. We are having 100 mg venetoclax only. We are giving it alternate day in the with the help of posaconazole. But if people are using or comfortable with 400 mg, which will be a lot of cause a lot of cost constraint, well, you can go ahead. And now we also spoke about FCR and the indications. If we are going to give FCR for a patient with CLL, what are the precautions we should be seeing? Fludarabine notoriously can accelerate autoimmunity. And the reason why autoimmune phenomena occurs with fludarabine is because it causes T cell lysis as well. It causes a lot of impact on T cells. and thereby increasing the risk of autoimmune phenomena. Like in ITP, how the pathophysiology was changed from B cell mediated disease to T cell mediated disease, the exact same happens because fludarabine has a good impact on your T cells. And because of that, it increases risk of autoimmune phenomena. We have seen cases of acquired hemophilia, ITP, hemolysis, Ivan syndrome with use of fludarabine. And so we have to watch for hemolytic anemia when you are using FCR. Always and always, before we are going to give FCR, ensure your direct womb stress is always done. And number two, it's a very immunosuppressive therapy. So caution and prophylaxis for opportunistic infections is important. And also avoid concomitant treatment with steroids wherever possible due to the heightened risk of opportunistic infections. And also 5-HT3 antagonist should be given on each day of treatment. And most importantly, once you have given a patient FCR, at least for the next 6 months, when we are going to transfuse, we would prefer irradiated blood products. So when we are giving FCR, always give a call to the blood bank and ensure they are knowing that this patient, whenever he comes for transfusion, be it platelets or PRBCs, they are always irradiated. So we have completed the protocols for, I think, DLBCL, CLL, mantle is the same. Follicular lymphoma also, every drug is covered. I'm just going to touch upon hairy cell leukemia, where we are going to treat cladribine with or without rituximab, and the other option being pentostatin. We are not, pentostatin is not usually easily available. We are also always giving cladribine. So cladribine, there are two ways of administration, subcutaneous and intravenous administration. They both have similar response rates. However, subcutaneous cladribine was associated with lower risk of viral infections and mucositis despite having a higher rate of neutropenia. In our center, I'm always giving intravenous administration of cladribine, despite studies showing that subcutaneous cladribine was associated with lower risk of viral infections. So what we should be very cautious is it's very, very myelotoxic. The patient is going to have prolonged cytopenia. As it is, a patient with HCL is going to come to you with prolonged cytopenias. And also this drug is also going to be extremely myelotoxic. So there is going to be at least 3 to 4 weeks of cytopenias. So we'll have to, give appropriate prophylaxis to the patient and also keep him on watch for any forms of opportunistic infections. No dosage recommended in mild cases of renal impairment or even hepatic impairment. In moderate to severe, cladribine is not recommended. And bone marrow suppression, there are multiple protocols of cladribine which is given, and the bone marrow suppression is dependent on the dose of the cladribine which we have given. And also, cladribine can cause severe acute nephrotoxicity and also severe neurological toxicity, resulting in irreversible paraparesis, and that is something we should be aware of. Now we come to this PI3K inhibitors. Very sad thing happening with PI3K inhibitors. It was celebrated too much. There were so many drugs which was approved. It was one of the way of B cell receptor modulation that we could do in treating B cell lymphomas. But it's a sad story when it comes to PI3K inhibitors. Okay, let's now discuss the mechanism of action. It inhibits proliferation and induces apoptosis in many B cell malignancies because it's acting via the B cell receptor pathway. So it inhibits homing and retention of malignant B cells and lymphoid tissues, reducing B cell survival. So this is the way of acting. It's downstream AKT pathway and also has its impact on the BTK pathway. So what was actually expected was it is going to be more potent than Bruton tyrosine kinase inhibitors. But our experience says otherwise. There are various PI3K isoforms. We are more concerned with the delta form and also the alpha form. We have idelalisib, which is a delta, umbralisib, the newer dualisib, which is a PI3K gamma as well, copanlisib, which has both alpha and delta, and buparlisib. So they say that when one door closes, the other door opens. It did not happen for PI3K inhibitors. So they had initial approval for CLL and relapsed follicular lymphoma. But what happened was the amount of side effects were so severe, mostly autoimmune, colitis, and even death. And it also caused the FDA to, say that single-armed trials should not be included. This drug was responsible for that. And for any FDA approval, the thought that it should always be a randomized controlled trial came into discussion solely because of this PI3K inhibitors. and the significant mortality risk and the adverse effects associated with PI3K inhibitors. So all the trials which led to its approval were all single arm studies. We didn't have a randomized control study if assessing its efficacy. And because of these side effects, there was voluntary withdrawal of duvelisib and umbralisib after its accelerated approvals very recently. So now we have completed the B cell small molecules monoclonals. Now we come for T cell lymphomas. The chemotherapeutic regimen is going to be the same. Of course, you are going to give L-asparaginase, which was also discussed in the acute lymphoid precursor neoplasms in the last class. So it is very grim. T cell NHL did not have much of drugs being approved. We had nelarabine and pralatrexate, which showed some efficacy with T cell NHLs. But then we also have the small molecules in the form of, EZH2 inhibitor, which is valametostat. We had HDAC inhibitions because we found there's a lot of epigenetic modifications which is happening. ALK inhibitors have been discussed in the solid malignancies. We have ongoing trials on CART, and JAK-STAT inhibition also has a role in T cell NHLs, but then it will be discussed in the myeloid. So we have a lot of novel therapies based on the fact that we have data. There's a lot of epigenetic modifications happening in relapsed refractory PTCLs. So we had romidepsin and belinostat, which received FDA approval based on an encouraging ORR of 25%, but then it was withdrawn. Romidepsin was withdrawn. We also have ongoing data of HMAs, azacitidine and decitabine are emerging as promising treatment options. And we had pralatrexate, which is nothing but a more effective methotrexate, the first FDA-approved therapy for relapsed refractory BTCL in 2009, with an overall response rate of 29% based on PROPEL study. PI3K inhibitors, which we have already discussed, are also having a role. JAK1 and JAK2 inhibitors are also having a role. Checkpoint blockades, we have already discussed in the solids. CARDS, we'll have a separate talk on CARDS and oncolytic biotherapy. HDAC inhibitors, vorinostat and romidepsin comprise the HDAC inhibitors with clinical activity in CTCL and also PTCL. And it was actually more useful in a specific subsets of PTCL, where we were trying to, molecularly target the specific epigenetic modifications which were happening. Epigenetic regulators such as TET2, IDH2, which were usually myeloid-associated mutations, were also seen with T cell malignancies. And that is the reason we thought maybe HDAC will have a good result in PTCL, but then it did not really happen. And we also have alemtuzumab. I have personally no experience giving Campat. It's a CD pan lymphocyte CD52 antigen. It's a monoclonal against CD52. So currently we had pralatrexate, brentuximab, romidepsin, and belinostat. 2021, we had removed romidepsin CHOP due to a negative phase 3 study. We still have brentuximab vedotin is the only drug we have currently, the newer drugs with PTCL, anaplastic large cell lymphoma, which has good role in treatment. As a matter of fact, anaplastic large cell lymphoma, it has BV, CHP has become the standard of care. And I think I've covered all the newer drugs as of now, except maybe the myeloid-associated drugs, which will be discussed in the next talk, and mogralimumab. And I'm on time with 40 minutes. Thank you.
Thank you so much, Faheema, for covering this topic so elaborately. So I think the nuances of couple of drugs like ADCs or bispecifics will anyway come up during the examinations time. So without wasting much time, let me invite the examiners first for today's E-Gurukul. So Dr. Gaurav Prakash is a professor in the Department of Clinical Hematology and Medical Oncology at PGI Chandigarh, and Group Captain Dr. Tilak, medical oncologist from Command Hospital, Bangalore, and two examinees, Dr. Atul Dongare is second year resident doing DNB oncology at Sahyadri Super Specialty Hospital, Pune. And the next examinee is Dr. Ronak, is a final year resident from Manipal, Bangalore. So over to you, examiners.
Thank you, Dr. Lingaraj. Thank you. And thank you, Dr. Faheema, for an excellent presentation, very detailed and elaborate. So can we have, can I request Dr. Tilak and other both examinees to turn on the video so that we can interact? Right. Dr. Ronak Raheja is there, and who's the second one?
He's not.
Atul, yes.
Okay, Atul.
Yes, sir.
Right. So you heard about the changing landscape, very rapidly changing landscape of lymphoma management, and there is no doubt that in years to come we will treat lymphoma quite differently. But still today, the standard king is R-CHOP chemotherapy. So let's start from basic and then we build up upon it. For example, if you are having a patient in your ward today, suspected lymphoma, biopsy is done and biopsy is expected to come tomorrow. So from the perspective of starting, say, either CHOP or R-CHOP chemotherapy, what preparation with respect to drugs or administration you will do today?
So first we'll check the performance status of the patient, ECOG performance status, and assess the fitness. We will check for hepatitis B serology to prepare for rituximab and ensure that there is no active hepatitis B infection. We can check for echo because of
For hydroxydoxorubicin.
And then we'll check for renal function to prepare if we have to titrate the dose, and hepatic function also we'll just check, and we prepare the patient for chemo.
Right. I think Dr. Atul spoke about hydroxydoxorubicin.
Yes, sir.
What is hydroxydoxorubicin?
Sir, it is it's an anthracycline.
Okay, so I think you got confused between it is a
No.
hydroxyl group added to donorubicin, and that makes it slightly more active. We still do not understand exactly why, but for solid tumor and lymphomatous tumor, doxorubicin has, and one reason can be chemistry, the other can be that traditionally they have been used more in these, and donorubicin variant, which is without a hydroxyl group, is more active in leukemias. Right.
Okay, sir.
Moving on to Atul. Is there anything you will do, some drugs that you will keep ready and procure day before or maybe a couple of days before? Yeah, aggressive lymphoma stage 4BX.
So we may expect tumor lysis syndrome. So for that in a prevention thing, we can ask for allopurinol, raspberry case, and fibrostat.
Okay, so you will give all three of them?
No, sir.
So how will you are now getting trained to treat. So
Yes,
what will you give and what will you not give? And if you have to give something, for example, raspberry case, the drug, how does it act and what special precaution you will take with raspberry case? What is the dose of allopurinol? Let's start simple.
Yeah. It's a 100 to 300 milligram per meter square. And
something more. Okay, can you build upon Ronak? Can you just?
Sir, for raspberry case, we'll see G6PD deficiency.
Very good.
Yes, G6PD deficiency.
So you will order for G6PD a day prior.
Yes, sir.
Okay. What is the dose of allopurinol? It may sound very basic, but then
300.
Yeah, so 5 mg per kilo is the dose. Is not meter square, it is dosed in per kg. 5 mg per kilo loading dose. Then you can give 5 mg per kilo per day, either in 3 divided doses or in single dose also given. Right. What is the mechanism of action of raspberry case?
Allantoin, it makes it soluble. It makes uric acid soluble and helps excrete it in the urine.
Correct. Very good. What is the drug itself? How does it do so?
It is allantoin.
No. Allantoin is the product.
Allantoin is a product, correct. Yes, sir.
Which enzyme does it inhibit? That's what Dr. Prakash is asking.
uricase inhibitor, uricase.
Atul, Dongare, can you just answer this? There are two enzymes. One is xanthine oxidase. You spoke about allopurinol and febuxostat, both inhibit xanthine oxidase. This is the next step. Is a recombinant urate oxidase, okay? So uric acid is changed to allantoin with the help of this enzyme. And if either this enzyme is deficient or overwhelmed, because so much uric acid is made that the naturally available enzyme is not able to convert the barrage of uric acid into allantoin. So therefore, you have to provide a recombinant copy, and therefore you do it. Right. Over to you, Dr. Tilak.
Yeah. So continuing with the initial preparation, in case you have to give raspberry case, do remember that during the infusion, the patient should be with a cardiac monitor. It's important. It's known to cause arrhythmias, etc. So you can monitor hemodynamically. So right. So disclaimer: I'm an old clinical physician, so more clinically oriented than the newer drugs, etc. And many of the newer drugs, I personally do not have experience. So, okay, clinically, which are those patients where will you suspect a double hit or a triple hit lymphoma? Because here is the place where you might have to change your protocol. So clinically, which are those patients where will you suspect the patient might be a DH or a TH?
So we'll see the prognostic score and we'll see if there is like extra nodal sites, the number of extra nodal sites, because which is the sites that are involved. Especially if there is extra nodal disease, we should suspect double hit or double expressor.
And anything in the biopsy you look at in addition to the extranodal sites in clinically?
The grade, the I mean size of the
subtype of the which subtype of DLBCL normally is expected to be double hit or triple hit? Dr. Ronak? Sorry, Dr. Atul.
So this high grade
GCB
diffuse
or
large
not
B-cell
GCB?
What are two
lymphoma.
subtypes? First, you can enumerate two
It's
subtypes.
it's
Of origin subtype.
GCB. It's GCB and ABC.
Yes. So
Two
which one will you
subtypes.
suspect a patient with extranodal disease to have? Probably DH or TH?
GCB, sir.
GCB.
GCB, very good.
GCB,
Right.
yeah.
So,
So
6% of the patient are likely to have 6 to 8% patient are likely to have. Yes, your probability, Dr. Ronak, what you were saying, the probability of having a triple hit, which is BCL. Can you tell me the 3 hits or 2
Yes,
hits?
sir.
Yes,
Yes,
please.
sir.
Yeah.
So 2 hits means MYC mutation, MYC with rearrangement of BCL2 or rearrangement of BCL6 is double hit. MYC with rearrangement of BCL2 as well as BCL6 is triple hit.
Very good. So what the point Dr. Ronak was making is that if you are having multiple extranodal site, more than 2 or 3 multifocal, then you can think of that this patient might have triple hit, but then you cannot end up testing. There is no algorithm as of now which is clinically proven. So therefore, in centers, if you have fund, you have to test for all, but the more than 90% will come negative. So therefore, still checking for double hit, triple hit out of the clinical trial is not a part, or protocol is not a part of the routine lymphoma practice. Yes, if you can do, then it's absolutely all right. So yeah, now we come to double hit. You are treating a patient, the biopsy came tomorrow, and double hit lymphoma is there. And so what is in your center or your understanding, which is a preferred regimen?
So for the double hit, we prefer this what we said.
So still we'll try R-CHOP once and we'll see the response. We'll try to stick to basic R-CHOP. If you're getting good response, then we can then see. If we're not getting response, then R-EPOC or maybe R-DAP or R-ICE. but it would and nowadays with latest advances, if affordability is there, Pola we can include Pola.
I will interrupt you here. So you said RDHAP and RIs. So there is a newly diagnosed patient of double-hit lymphoma. Would you be willing to use RDHAP or RIs therapy?
No, not newly diagnosed, sir.
Second
Second
line.
line, salvage line, sir. Sorry. Yes, sir.
Right. So even if it is a high, we know that the outcome with the standard RCHOP or variant like DA-EPOCH are not optimal, but still that does not make a case for using second line regimen upfront. Now coming to DA-EPOCH, how do you administer rituximab and cyclophosphamide in DA-EPOCH?
Sir, DA, ma'am told, is dose adjusted. So we will first start with a very low basic dosing, and then 1 to 7 plus and minus 2 ways. So you can keep
that is dose adjustment. I am saying how will you administer them? Because Dr. Faheema spoke at length about how the drugs are given. What is the difference between RCHOP and EPOCH? The drugs are same except etoposide, or anything is different. The way you know something.
Yeah, that's a good question. How is DR-EPOCH different from RCHOP?
So I will keep increasing the dose every cycle, sir.
RCHOP is given in how many days?
Fixed RCHOP, we have our fixed protocol. So we will stick to the same RCHOP dose. And our EPOCH, we will start with low dose and every cycle keep escalating and see if they're tolerating well or keep decreasing in subsequent cycles.
But
So,
more fundamental, yeah.
So in a cycle, what is the difference between RCHOP and DR-EPOCH?
Dosing.
RCHOP you give in how many days?
15 days.
No. That's
the frequency of the cycle. But on the day of chemotherapy,
1 day.
1 day, right? So
yes, sir.
Got a clue now? How is DR?
Yes, sir. That is over 6 days. No, over three days. Our EPOCH. Dose adjusted EPOCH.
96 hours.
96.
So actually 5 days. It becomes close to 5 days.
Yeah. So on 5th day, what do you do?
Yeah.
So that
so that's what Dr. Gaurav is asking. Now get the clue. His first question and now. Rituximab and cyclophosphamide, you give on the same day in RCHOP. What happens in DR-EPOCH? Have you given in your institution?
Yes.
No. Okay. So no problem.
Okay. All right. So I think the point to remember that both rituximab and cyclophosphamide are standard short infusion, and they should not be given long infusion. The three drugs, Vinca, anthracycline, and etoposide, they are actually mixed together. And because they are photosensitive, there is anthracycline is there, so you have to wrap. And Dr. Faheema very nicely explained that. Dr. Tilak.
And cyclophosphamide is given day 5
on
the last day. It's not given the first day, right? And the basic mechanisms is still not very clear, like Dr. Faheema mentioned. But probably one of the ways is that it reduces it's basically to do with the pharmacokinetics, and based on some phase 1 study, or in fact preclinical studies, where they found that the mechanism of resistance to the cells is reduced. So the response is slightly better. Right. You did mention something about in the beginning that we'll give RCHOP and then we'll change if there's not good response. So in the current scenario, what is the data on PET-guided escalation or de-escalation of therapy in non-Hodgkin's lymphomas?
So after in Rathil was risk adapted. That was in non-Hodgkin's we'll do PET scan after 4 cycles, and after 3rd or 4th cycle we will see if it is localized disease, then we could introduce some radiation. But if it is diffuse, like advanced disease, the PET scan will help either continue the same treatment or change it to a more advanced regimen.
Okay.
After
I think the data still is not very clear whether you should escalate based on PET-guided, what is called interim PET. the IPET data. So 2 cycles and 4 cycles PET, though there's a prognostic significance where a good response at the end of 2 cycles says the patient will do well. But dose escalation or protocol escalation, the data is not very clear. Dr. Gaurav, any thoughts on this?
Yeah. So dose escalation strategy as of now for DLBCL or for NHL is still experimental. For Hodgkin lymphoma, it is very well established, and we shall discuss that. Yeah, coming back to drug, before we go to other subtype, it is very important. Still, I maintain, and all of us, Dr. Tilak, including, that rituximab is the most important drug available for us, which is a targeted drug apart from chemotherapy. Can you tell us, for a patient who is going to receive rituximab for the first time, how will you start an infusion? How will you plan? What will be your chart order will be like? कितनी देर में ड्यूरेशन में देना है, कैसे देना है, प्री मेड क्या करना है?
Dr.
So,
Atul?
yes, sir. So we will start with the pre-meds, like Avil, steroid, Dexa, and anti-vomiting. And then we will start with the 50 mg per hour initial dose. We will mix it in a normal saline or according to the body surface area of the patient. And we will start with the 50 mg per hour initial dose. We will see the response and any side effect. If there is no side effect, then we will increase it into after an hour to 50 mg per meter square, and we will go
I will like to just intervene here. Is it like milligram per meter square per hour or something else 50? Your figure is correct numerically.
Sorry, sir. It's a 50 ml per hour.
No, correct. That is correct. So you reconstitute the drug, which is actually 375 milligram per meter square. The standard one is that you reconstitute everything.
Yes, sir.
So that is a Western way of giving it. In our country, because it is an expensive drug, now that not very expensive. So what we used to practice and teach is that you initially reconstitute 100 mg and start a test dose. And
Yes.
the acute type 1 hypersensitivity will happen in few seconds. After that, you can just add everything, which is usually 600 or 700 mg. And then what you are saying is you start with 50 ml per hour and you wait for how much time?
For 1 hour.
No, 30 minutes.
Okay.
If there is no reaction, what will you do?
We will increase the dose.
To?
Again with the 50 ml per hour, and then we slowly increase with the till the maximum dose 400 ml per hour.
Right. So actually you increase by 50. So that is first half an hour, 50 ml per hour, no reaction. Second half an hour, 100 ml per hour. After that, 150, and then rest of the infusion you can finish. So 3 increments are fine, and after that you can start with full dose. Subsequently, second dose, how will you give?
Second dose, we will start with the 100 mg, 100 ml per hour, and we will increase with.
There is a catch. So like if there is no reaction in the first cycle, subsequent cycle you can start at a steady rate, but the rate should not exceed more than 400 ml per hour, which is the maximum defined for this drug. So Dr. Tilak, next part.
Yeah. And don't forget that since you're blocking the H1 receptors with Avil, you should block the H2 also with ranitidine. It's also added as a pre-medication.
Ranitidine, yes.
So
may I request Dr. Tilak, Dr. Lingaraj is also around, he's the convener. So can we include him? And Lingaraj, feel free.
Yeah, feel free to ask some questions.
And Faheema, if you are around, and because you all the hard work. So
exactly.
So Atul, so what kind of reaction patients develop with the rituximab?
The early hypersensitive reactions, which may result into pleuritis, itching, erythema, or urticaria like pictures, and then may result into the bronchospasms.
Okay, so what is the mechanism? Why this patient develop this kind? What is the basic pathophysiology of this? What is the
due to
conventional
release.
way a
Yes.
hypersensitivity reaction occur? When you say, it's a severe hypersensitivity reaction, it is typically mediated by IgE, right? Then you don't
Yes.
usually, if you see such reaction in with any chemotherapy drug, you never re-challenge that, right? Because it is IgE mediated, right? But what do you do with rituximab, and what kind of reaction it causes, and what is the mechanism? Yes, Ronak?
Sir, it is a chimeric monoclonal antibody, so it will have that anaphylaxis-like reaction.
No, you really don't use this term in rituximab. It is not an
Type of reaction, class 1
whenever you
type of.
deplete B cells, it creates a cytokine storm. That's why whenever there is such reaction, you can re-challenge, because you don't have this reaction again from the subsequent cycle. But if it is a IgE mediated hypersensitivity reaction, typically the conventional teaching is you don't give the drug again, right? But in rituximab, even if the patient develops severe reactions, it is not a IgE hypersensitivity. It is a cytokine storm.
Okay.
Onwards, they usually tolerate. Okay.
Right. So now, should we go to the presentation, or should we take an exam like this?
I think so there are some questions made. You can actually show the presentation.
Okay. So if somebody
Karan?
the organizing side can share.
Yeah.
Yes, so we are projecting.
Okay.
Yeah.
Yeah. So Dr. Gaurav, you can start and then we'll carry
Okay.
on.
So can you, both the examinees, can you see this?
Yes, sir.
So this drug was discussed by Dr. Faheema. Can you just, by seeing this diagram, can you understand or tell us which drug and what mechanism is being discussed? Is shown here. And so the red part is nucleus and the yellow part is a cytosol.
Selinexor or something, sir. Is it Selinexor?
Very good. And yeah, what is selinexor?
Selinexor is a nuclear pore. It is a
Transport inhibitor.
transport inhibitor. So it will block that nuclear pore, which XP1 that protein will go outside, and it's used even in stem cell mobilization. I'm sorry, sir, but Selinexor.
It is not used in stem cell mobilization. It is used in another hemat malignancy, but not in stem cell mobilization, as far as I know. So your answer is right. Sorry?
That is plerixafor.
That is plerixafor. Yeah. So
Selinexor is different.
Yeah. So selinexor, what is the way of administering it? If you are aware, because selinexor #1 is not launched in India, and it is not a very, very impressive drug actually. So both for myeloma and lymphoma, there were two trials, Boston trial and Saddle trial. One for Boston was for myeloma and Saddle trial was for lymphoma. Phase 2 trials, and they showed modest activity. The only thing is that the patient who are against the wall, not many options are available. This drug used to be one option, but now with the advent of BiTEs and CAR-T, most likely this drug is not going to be a very useful option. The one good thing is it is an oral drug. We can go to the next question, I think.
Yeah. So Dr. Atul, unless he's busy, then Ronak can take this. What are the mechanisms of resistance of CAR-T therapy?
Sir, Atul,
The question is not completely visible.
So it's visible. So I don't know, sir, exactly, sir.
Okay. So there are two ways in which CAR-T19 therapy can be having resistance. One is directly related to the antigen, and other which is not related to the antigen. So related to the antigen, there can be mutations of the CD19, right? And eventually causing a alternate splicing of CD19, causing the antigen to be morphed or altered, causing lack of attachment of the CAR-T to the antigen. Second is if there is a CD19 promoter hypermethylation, right? Because it is promoter hypermethylation, the CD19 gene is not expressed, and that leads to reduction in the CD19 gene expression on the cells, which can lead to reduction in the efficacy of CAR-T cells. And of course, if there is an epitope masking, right? And by the CAR transgene. And if there's also a lineage switch, suppose the cell changes its lineage from a CD19 to some other lineage, then of course there's a failure of the CAR-T therapy. And things that are not related to the target antigen include structural aberration in tumor-selected other genes, basically activation of the alternative pathways by which the tumor cell can leave the efficacy and become resistant to the therapy. Some apoptosis defective pathway defects can also lead to resistance of the pathway. And as we know that there is always a co-stimulatory molecule which is required for activation. So in case there is a CD58 alterations, then there is also a reduced efficacy of the CAR cell therapy. Maybe with the higher generations of CAR T cell therapy, this particular thing may be overcome, right? So if you have to write an answer, it will be like this: related to the CD9 target antigen and unrelated to the target antigen. Next.
Right. So this is again the same
Very
drug.
nicely discussed by Dr. Faheema.
This was very well discussed, and PIK3 inhibitor, and again the drugs are withdrawn, so we can rather I will utilize this time to discuss a drug, polatuzumab vedotin. So while using polatuzumab vedotin, since the drug is launched, is there any subset of patient where you will be more keen in using this drug in DLBCL?
Activated B cell type is where we've been more keen, sir, because it is a differentiated B cell, and Pola is an antibody to the B cell receptor CD79B. So that will be expressed better.
Yes.
That is expressed better in the non-germinal center type of differentiated B cell. So the response was also better in activated B cell subtype in Polarix.
Yeah, so while your answer is partially correct, but then CD79B is a pan B cell marker. It is equally present patient who are having GCB subtype of DLBCL also. The reason is because in a subset analysis in the POLARIX trial, the confidence interval was much more significant for patient who was subset of activated B cell type. Any other in that trial, if you have read, any other subset which benefited clearly more than other? Age-wise or gender-wise, do you remember? Because it's an important trial. After like 20 years, something new has come up for clinical application. Atul and Ronak, anybody? Okay, so younger patient, and especially it is male also, it was found that they benefited slightly more, right? What is the adverse event profile of polatuzumab vedotin? Atul?
Yes, sir.
Adverse
So
event?
first, yes, sir. So first the dose related hypersensitivity, the patient the acute reactions, then the adverse effects, nausea, vomiting, myelosuppressions, then increase transaminitis, then this tumor lysis syndrome, and
Peculiar, some peculiar.
and some
Neuropathy.
neurological symptoms, sir.
Peripheral neuropathy.
Peripheral neuropathy, yes, sir.
And did you tell myelotoxicity the commonest one and dose limiting in these patients? Myelotoxicity बताया आपने?
Yes, sir. Yes, sir.
Okay. What is the active moiety in polatuzumab? Drug कौन सी होती है?
It's MMAE,
Very good.
monomethyl ornithine E.
Very good answer. Which other monoclonal antibody carries this payload?
Brentuximab.
Okay. What is the dose of brentuximab?
When we use as a single agent, it's 1.8 mg per meter square, 3 weekly, and when we used along with the AVD, it's 1.2 mg per meter square, 2 weekly.
Okay, very right. Apart from Hodgkin's lymphoma, what are the other approved indication of brentuximab?
Refractory settings of refractory and relapse settings of
Which subset of lymphoma? Which
Yes,
subtype?
sir.
Which one?
Refractory we have, upfront we have.
Okay. Mm,
Yes, Ronak, you can come in.
Sir, internet issue. BV, which subset are we using brentuximab, sir?
Apart from Hodgkin, which other subset was? Sorry, asking.
Which other type
In
of
DLBCL, no, peripheral T cutaneous
Yes.
lymphoma,
cutaneous
in
and
peripheral
systemic
T,
both?
in peripheral T cell lymphoma, in advanced line, they had tried brentuximab.
Every
What was the
PTCL you use?
trial? What was the trial which approved for PTCL? If you know the trial for Hodgkin, you will know
Echelon
Echelon
trial.
2.
Echelon 2 trial, sir.
Approval and Echelon 1. Okay. If you are giving for PTCL BV, what will you do with the main chemotherapy body as far as drugs are concerned?
Any change you will do in the
CHP, B, like CHP, O we will emit
Why?
or omit. Because of oncobin,
The answer is correct, but you have to explain.
neurotoxicity, because of neurotoxicity,
Uh,
because
we will avoid Bentux, this in Hodgkin lymphoma. If we are giving brentuximab, we will avoid bleomycin to prevent the pulmonary toxicity, and
O we will emit in
Correct. So both answers are correct, and the reasons are also correct. Can we move ahead in the presentation?
The next one.
Next after this. Next.
Yeah, so this was discussed by Dr. Faheema.
Yeah.
Right. So, Dr. Ronak, can you read the question?
So,
and
PET CT shows a patient with stage 2 bulky Hodgkin's lymphoma. Based on Echelon trial, discuss how brentuximab vedotin might alter the standard treatment paradigm. What PET adapted decisions could be made after 2 cycles? Sir, this bulky lymph node greater than 1/3 of the mediastinum is seen over here.
Yes.
Greater than 10 centimeters, we define as bulky. Some trial told 7.5 also. But in case of bulky lymph nodes, brentuximab might alter as by using brentuximab. Because it's bulky, it's an aggressive disease. And because it's aggressive, it is better to step up the treatment to brentuximab by starting in first line also. Brentuximab vedotin in aggressive disease. And after PET, after 2 cycles, we can see the response to BV-AVD, and then we can either continue BV-AVD or we can escalate to second line or salvage kind of regimens.
Okay. The Echelon-1 trial, what were the outcomes results with BV-AVD versus standard ABVD? Any idea?
How much
Sir,
incremental advantage, Dr.
Sir,
Tilak?
Hodgkin's, we get very good response with ABVD also. So
Yeah.
the increment is very very small, like 95,
so
93.
What was it only response rate? Was it OS? Was it PFS?
PFS benefit, sir, no OS benefit.
Yes,
There was, I think, 6-year OS benefit also with Echelon-1.
Yes.
With BV-AVD. BV-AVD.
5%.
Yeah, 5%.
5%.
Yeah.
So well benefit.
Right.
Any other sequence of adding BV with AVD which you are aware of? One is what Dr. Gaurav mentioned, you use BV-AVD upfront. Any other sequence?
Sir, if we started with the ABVD and we do the PET CT scan, and we found that the response, the PET CT scan is still positive. DVL score is on a higher side for it's on fifth. So at that situation also we can replace bleomycin with the brentuximab, and we can continue with brentuximab with AVD.
Okay. So there's another regime also where you can sandwich the AVD between BV. So give 2 cycles of BV, then give AVD 2 cycles, and again you continue with BV. There is another sequencing of or introduction of BV into the treatment paradigm of Hodgkin's lymphoma, right? And was there any benefit in elderly patients with BV AVD in echelon 1? So yeah, so they did not find any specific benefit that that you could use BV-AVD only in elderly as a subset analysis. So that benefit was not so much there in this trial.
Yeah. So you spoke of AAVD for Hodgkin lymphoma, both the examinees. There is one more chemotherapy backbone with which frentuximab is paired and used for upfront treatment of high-risk Hodgkin lymphoma. Can you name the regimen, and are you aware of the results? A recent trial, not very old, last year. You just remember
BV and nivolumab. BV
No.
nivolumab.
So that's not a chemotherapy standard backbone.
Yeah.
BV nivolumab is not a frontline treatment. Yes, most of us are, looking forward to have some frontline data, and, but as of now, Nivo and BV combination is not a treatment. Okay, I'll help you. What is the standard treatment? Forget targeted therapy. Only chemotherapy is standard treatment for Hodgkin.
ABVD and radiation.
ABVD. So if you want to be more aggressive than ABVD, which is the regimen? Upfront.
BA-COP.
BA-COP. So in BA-COP now, the latest one is combination of BV. So what is the regimen? BRICAD. It's called BRICAD.
Yes, sir.
Because you have to take off bleomycin, and you have to also take off procarbazine, because procarbazine is more gonadotoxin, myelotoxic. So it is replaced by dacarbazine. So BRICAD regimen is there. So that can also be used upfront in high-risk patient, including BV. Okay.
BRCADD.
Yeah, BRCA. How much time can I ask?
R small.
Examiners, sorry, organizers, how much time is there for the?
We have about 5-6 minutes.
Okay, move to the next slide.
So we have a couple of minutes. I mean, we can take more questions if you want.
Okay, so CAR T cell,
I think
we will skip because there's a
Is it
different.
good?
Next.
Next slide.
This was discussed already. Yeah.
This was discussed, I think. Ye to ho gaya.
Yeah,
Next. Which is not a bite, is a quiz question. Would you want to take it? What is bite, quickly?
Bispecific.
Bispecific T cell engagers.
Okay, so can you find one drug which is not bite, which was presented by Dr. Faheema? It will show how attentive you were.
Okay.
Tafasitamab. Tafasitamab is a drug which is monoclonal antibody. It is given in combination with
excess. Yeah, it's a CD19. Okay, yes, sir.
Right. So, in this list, I think except Blina, most of the drugs are not available to us. So theoretical. Suvostamab is a bite for myeloma. Teclistamab is a bite for myeloma. So there's a mixture of things. Next slide. Yeah, this is very important. Dr. Tilak, can you just lead this?
Yeah, so you have a patient who's turned out to be HBCG positive prior to rituximab-based therapy. How will you proceed? What are the guidelines available for?
So HBsAg, we need to not only look at HBsAg, we need to look at the entire profile. And we need to see
By profile, you mean?
The DNA count of hepatitis B DNA.
Hepatitis B virus,
Yeah,
load.
You want to see the replication status and the HBV DNA.
Yes, sir. And then we want to see if the core antibody is positive. If there's active replication, we want to see if HBE is also there to see how active the hepatitis B is and how aggressive it is. Then based on the activity, we will put antivirals antivirals for
Which are
anti-hepatitis B.
approved antivirals? What was
Entecavir.
used earlier and what is currently being used in clinical practice?
Entecavir is approved,
Entecavir.
sir.
So
Now
earlier
we used to use
earlier they used to use
sulfasalazine.
lamivudine. They used to use
Lamivudine, sir. Yes, sir.
Yeah,
Yes, sir.
nobody.
But now it just entirely become either entecavir or
A, something from A.
tenofovir.
Tenofovir, yes, sir. Tenofovir, yes, sir.
Tenofovir.
200.
Yeah.
Yes, sir.
Tenofovir. Abacavir also used to be used, and but nowadays they use tenofovir, and tenofovir also has got two salts. One is TAF and one is TDF. Right. So the TAF is supposed to be slightly more better. Right. Just a pure medicine question. What are pre-core mutants? Have you heard an HBsAg pre-core mutants?
Yes, sir.
Harrison. This is not
Yes,
Devita.
sir. HBS, HBS AG, HBS, HBS E, and what?
Yeah, so basically these are people who are actually replicators, but the serological markers of replication are not there in the testing. So he might be HBeAg negative, but actually he's actually showing high HBV DNA, right? It's because if you see the genome of the HBV, there is a core, there's a pre-core, and then there is the S, etc. So in the pre-core there is a mutation. The CAG and EAG do not show up well, giving you a false impression that this patient is a non-replicator, right? Right, next. Yeah, by the way, how long will you continue the therapy? The beyond completion of R, say you're giving 6 R-CHOP. How long will you continue entecavir?
Till we get non-detectable HBV DNA.
Yeah.
DNA तो है ही नहीं ना, जरूरी थोड़ी DNA. HBs antigen positive, no DNA detectable. Will you not start entecavir?
We will give it during therapy, sir, and then 6 months, after 6 months, we will, after the last rituximab dose, 6 months it takes to recovery of the CD20 cells. So we will continue with 6 months, and then we can, after 6 months, we can discontinue if we are confident that there is no active disease.
Yeah, so it's only HBsAg positive, but it's not showing any HBV DNA. You start entecavir, give the chemotherapy, and for 6 months you continue the, later, after completion of the chemotherapy, you give the entecavir.
Yeah. So I think the key point is that we count 6 months at the end of after finishing chemotherapy, not from the date of starting, because that is the minimum time for B cell reconstitution, especially after rituximab. Next. Yeah, this is again very important, and it was nicely presented. Yeah. What will you do? So like you told us about what you will do before the starting R-CHOP, what you will do starting FCR, before starting FCR. What precaution, what drugs?
Hemolysis syndrome, we have to be very CLL.
Okay. Hemolysis is one.
And rituximab precautions we will also take, whatever we have to see for rituximab. And cyclophosphamide also, based on dosing, we will see like there's if it is high dose, but in FCR usually we don't give very high dose cyclophosphamide, so we don't need to give Mesna and all. But then also we have to see for opportunistic infections such as like PCP, and then we have to make sure that Shingrix also is given, and then
Shingrix for PCP.
No, sir, Shingrix for herpes, but also TMP SMX backbone, bacterium backbone, we should give to prevent reactivation.
And prophylaxis and vaccination, you may or may not find time to give, but then it is always a good idea to consider Shingrix vaccination, herpes zoster, yeah.
And then hepatitis B, because of rituximab, we have to check, and then CMV maybe if affordable.
CMV monitoring is not required, but then you will keep a high index of suspicion. And it was told in the presentation that you will the risk of hemolysis as well as requirement of irradiated blood products. So you will keep in mind these two. We have, I think, 5 more minutes.
Showing us time up.
So we have couple of minutes. I mean, we can go up till 4 o'clock, but I mean, as you're comfortable, sir.
Okay, next slide. Let's finish the slides first, and then we'll have some ad hoc questions. Yeah. Bleomycin. Dr. Tilak, please.
Yeah. So what rash is this?
Main two drugs that may cause this and manage of this.
What is the finding? दिख क्या रहा है आपको?
So elevated rash, scratch mark, the carbon.
More common?
Bleomycin. That bleomycin, the whale, like the reticulum, there's that the blackish colored discoloration also will be there.
Flagellate rash. It's a flagellate rash, is it?
Yeah. Flagellate rash, like a whiplash injury. Although this is not best of the image, but if you see,
generally the flagellate rash is not so raised, nothing else. It's more flattish. It's more with the skin, but you can see it, like, on the back of the body, like nice, like linear blackish discolorations classically seen with bleomycin. Let's have the answer. Next slide, please. Yeah. Back. One slide back. Yeah, the flagellate rash, right? So it can be seen both with bleomycin as well as with bendamustine. And just stopping of therapy is the only treatment, nothing else. And generally, it's not very. Most of the cases do not require change of dose or stopping of therapy. We can manage it by continuation. Next.
I just have a small point here to make. Bendamustine shows extra toxicity when it is given in combination with allopurinol. So the student should keep in mind that because you are very much likely to give allopurinol to any lymphoma patient. And if we forget these interactions, and the incidence of skin toxicity will be more. So if you have to give TLS prophylaxis, you give it, but then stop allopurinol few days before giving bendamustine. That is one learning point. Right. Next, I think PolarX we have discussed.
This was discussed, yeah.
Yeah, 6% benefit.
OS benefit, only PFS benefit.
Yeah, so that is an important point because the drug cost quite a lot. Can you just tell me the current cost of polatuzumab, one patient per cycle?
3 lakhs.
No, so it is
with support 9 lakhs.
4.5. It is nearly 4.5 lakhs without support, but with support it comes to like 1.5 lakhs per cycle. So it is exorbitantly priced because it's a proprietary drug. So I think we should be open with the patient and tell them that there's a progression-free survival benefit only as of now. Future subsequent longer follow-up, we may learn more. We may get to know whether overall survival benefit was there or not. However, for a certain subset of patients, this remains a very effective and good drug. And next, please.
Yeah.
CNS ICANN. Okay, so how do you, because now BITE and all, have you used any BITE?
They've had a class on CAR T cells? No, not yet.
Not yet, sir. Okay. I mean, it was a bit discussed in the ALL session, but we are still to go with it, sir.
So what is the mechanism of cytokine release syndrome? Because you are going to not only hear, but see these complications much more than we did. So.
Sir, okay. Yeah. Tell me.
Bolo, koi bhi, one of you.
Yeah, Ronak, bolo.
Sir, because CAR T cell is, T cell driven, it will, T cells when stimulated will release all the T cell cytokines, like interleukin 2, 3, 4, 5, like whichever is T cell specific. So T cell will release interleukin 2 to stimulate more T cells, and T cells will secrete interleukin 4, 5 to activate B cells. Then T cells will secrete cytokines to activate macrophages. So that's why when we are activating a T cell, it over secretes all these cytokines with even to upregulate the to activate the entire immune system, and that causes the cytokine release syndrome.
What is ICANN?
A neurological toxicity when we give CAR T cell, and we should make them write like while giving CAR T cells daily, we should make them keep writing to grade neurological toxicities, because it is very neurotoxic. So we have to monitor.
Yeah,
it.
immune cell therapy associated.
Immune cell associated neurological syndrome, ICANS.
Neurological.
So what are the treatment options that we have against CRS?
So we can give steroids. Yeah.
Sorry?
So, sir, first we will stop we will hold the drugs, and I mean, we will give steroid. We will, to decrease the things, we can try Mannitol or other osmotic agents, but there is no such benefit observed with the Mannitol or osmotic agents in ICAN cases due to result of this chemotherapy, I mean these drugs. So the steroid is the mainstay of the treatment, sir.
Would you like to
Interleukin 6 antibody also.
What is that?
Interleukin 6 antibody.
This is small molecule.
Tocilizumab.
So,
We will give.
Atul,
Yes, sir.
yeah, I'm coming to that. Would you like to change still? You said that steroid is a mainstay. Why steroid? I'm disagreeing. So I'm asking you now, why steroids are not the mainstay of treatment of CRS in patients, especially those who receive CAR T?
Sir, I'm sorry. I was taking it as a PML. So it was like so.
PML? What is?
Yeah, sir. I'm so sorry. I got confused.
But you thought differentiation syndrome of
Yes,
arsenic.
yes.
Okay.
Yes.
So now,
So
what is the treatment? Two drugs you named, both of them. The first, why I'm asking again, why tocilizumab becomes a first choice over steroid in these patients? Otherwise, steroid inexpensive, 10 rupees injection
yes.
also, but still, we are not saying. Yes, Ronak?
So the steroid will kill the T cells which we are giving, the CAR T cell, which is so costly. 1 crore. If we give steroids, the whole thing is gone with the steroid. And then
so while very correctly said, while steroids are going to be effective because they have high lymphodepleting action, they will deplete activated T cells, but they will simultaneously deplete the coexisting CAR T cells therapy. And CAR T cell success not only depend on the immediate action, but also persistence of CAR T cell in the circulation for longer duration. So which tocilizumab will not touch, because it is only going to act on the cytokine, not on the cells.
Yes.
Therefore, it becomes important, even if tocilizumab is more expensive than Dexa or prednisolone, but then in larger picture, it is next. Next slide. Right, next slide. Next slide. And what is right? So, sir, Dr. Tilak, any open?
Yeah, I think we can. Yeah.
We can stop the presentation and go to Dr.
Yeah, I think we can stop here, and any open questions from the students?
Yeah, any chat box question?
Yes,
Dr.
sir,
Lingaraj,
we have some questions directly from the students, sir. So maybe I can ask.
Yes, please.
I think, sorry, Lingaraj sir is there.
Yeah.
So maybe I can ask those questions. Okay. So one question is from Hodgkin's lymphoma space, that in BCOP regimen, what is the rationale of dose escalation of etoposide and doxorubicin? and what are the risks?
In the BCOP regimen,
Yeah, so I think this question is specific for escalated BCOP. So why the conventional BCOP and escalated BCOP?
yeah, so BCOPs, I mean, traditionally started by the Germans. They were very fond of using BCOP and and they found that in younger patients who are fit and where if the response is likely to be better and the initial response has not been that great, so they have escalated BCOP. But personally, I do not have any experience of using BCOP in my clinical practice, so I don't know about clinically how would escalated BCOP be effective. Dr. Gaurav?
Yeah, so escalated BCOP, it's clearly the relationship between dose toxicity. So we gradually increase, and we would want to give the drug till the maximum tolerated dose. It showed better responses, but as Dr. Tilak said, outside of Germany, not many people use escalated BCOP. In India also, most of us use BCOP regimen because the incidence of infection-associated adverse outcome is much higher. Environmental and multiple other reasons are there. But if some centers are using escalated BCOP, then if you have that control environment, you can very well use it. And there is a clear algorithm how to escalate and reach the maximum benefit possible.
Yeah, so we did this study at TMH with escalated BCOP. So I mean, I agree with Gaurav sir about the toxicities, and the basic reason is Goldie-Coleman hypothesis that you increase the dose, you reduce the chances of getting a tumor resistant clone. That was the whole premise of escalating the doses of chemotherapy. Okay, so next question is vincristine and vinblastine are both vincalcaloid. Why is vinblastine not used in CHOP for aggressive lymphomas?
So it is for exam nuts or examinees?
So this is for actually everyone.
I think their queries they're asking.
Yeah.
So first
Yes, sir.
exam, then we may try our luck.
Yeah, examinees, can you answer this? Why vinblastine is not used?
CNS penetration.
It is to do with the evolution of drugs, because the drug that came first was oncovin, right? So vinblastine came much later. So that's how, if you see the famous Devita regimen, it was CHOP, and that was the only drug available. So vinblastine come much later in the development.
Yeah, and the other reason is the cumulative myelotoxicity, because in CHOP backbone, if you replace Vinca with the vinblastine, your myelotoxicity is going to be significantly. So these are two reasons.
Yeah. So the next question is how etoposide addition in CHOEP improves outcome in T as compared to CHOP, any subset?
Yeah, so the data is very much clear. Only patient who had ALK positive ALCL, they benefited significantly with addition of etoposide. In all other patients, we add with a good faith of doing something additional, because otherwise the outcome of PTCL, especially PTCL NOS, is very poor. But the data did not show significant advantage of adding etoposide. Yes, you are adding some more toxicity. So clearly, ALK positive ALCL, add etoposide and get a statistically significant benefit.
Yeah, so unless you're using etoposide in the regime like the DR epoch, where you're giving a continuous infusion, we're getting a pharmacokinetic and a dynamic benefit. There is no overall efficacy of addition of etoposide unless it's an ALK positive ALCL.
Yeah. So next is, I think, is a broad question that he asked, is treatment strategy for HIV positive DLBCL. So
yeah, so that was one of my questions of clinical associated, that what are the treatment plans for HIV associated lymphomas. So I think this one of our examinees can take this. It's a common question usually asked.
Yeah.
How will you manage HIV associated DLBCL?
I have to give antiretroviral therapy first.
For lymphoma, how will you treat?
First, we'll try to start antiretrovirals and then.
अरे भाई HIV patient antiretroviral पे तो होगा ही ना?
So
you want to say
this is newly diagnosed.
Newly, okay.
So first we'll try to target the retroviral thing, and then we'll check the CD4 count, and then we'll also we'll check the viral load. And first we'll try to bring the viral load to some controllable level, to like as much as possible try to make it undetectable, and then start off with RCHOP with stringent monitoring of viral load along with the regular chemo.
What about the lymphoma regime? What would you like to use in these cases?
Maybe if RCHOP is RCHOP itself also.
Yeah, so there's one subset where again DR-EPOC does very well. You know, Burkitt's lymphoma, HIV-associated lymphoma, primary mediastinal B-cell lymphomas, double hit, triple hit. There are probably some of the subsets where DAR-EPOC is showing more benefit than standard R-CHOP. And yes, antiretroviral therapy has to be combined. I mean, nowadays the guidelines are very clear. Whatever the CD4 counted diagnosis, you start the ART, right? And in the ART, what about drug interactions? Are you worried about drug interactions with the lymphoma drugs? What about protease inhibitors? The PIs? Ritonavir?
Emtricitabine.
No, ritonavir.
That psychological.
No, so these drugs induce CYP. Yeah. And so they are likely to cause less efficacy of the chemotherapy agents. So in these agents, you would like to use any of these like dolutegravir, etc., either integrase inhibitor or an entry inhibitor, right, into the regime rather than using a protease inhibitor in the ART. So HIV-associated lymphomas can be a long or a short question.
Yeah, there is one particular type of B-cell lymphoma which is seen much more commonly in HIV. Which is that?
Primary CNS lymphoma.
No, most of the primary CNS lymphoma, I think Lingaraj's paper and our paper is clearly shows that in India, incidence is very, very low. One more subtype of lymphoma, bordering myeloma.
Jaw lesions.
Burkitt's
Jaw lesions. No? Anything else?
No.
Bordering
Bordering
myeloma.
myeloma, that's a good clue.
Yeah, Atul.
Plasmacytoma.
Plasmacytoma. Plastic.
Plasmablastic. Yes.
So again, you can use more aggressive regimen in that separate. Okay, I wanted to ask
and
one
primary effusion lymphoma also.
Primary effusion lymphoma, body cavity, HHV. Which virus? Primary effusion lymphoma. HHV8, human herpes virus 8. Yeah. Any other question, Lingaraj?
Yeah. So one thing is about the role of marrow in DLBCL as a staging. Maybe Gaurav, sir, you can take.
Yeah. So there is a divergent view. The general view is that if you are having PET functional imaging, and in functional imaging you are finding bone marrow involvement, you do not need marrow separate confirmation. But if the marrow is negative, patient is having advanced disease where a marrow can up a stage, then the marrow is needed. This is a fine point. In general, what we believe that if PET is negative predictive value of PET is very high, we can avoid bone marrow. But we have to understand this negative predictive value is for nodal disease. Marrow involvement by a lymphoma is very small and patchy. So it's not a large lesion. So therefore, marrow which is lighting up in the PET scan is positive clearly, but marrow which is not showing up, if you really want to stage, then you have to do a bone marrow. Yes, stage 1 lymphoma clearly, short lymph node, stage 1 or early stage Hodgkin lymphoma, if PET is negative, you can obviate the need of doing a marrow. But otherwise, say stage 3 DLBCL or Hodgkin lymphoma, PET is negative for bone marrow and you want to stage optimally, then you have to do a bone marrow examination.
Thank you, sir. So bleomycin lung toxicity, is there any first or second line management?
Dr. Tilak has managed a couple of cases, I remember, when in fellowship.
Yeah. So bleomycin lung toxicity, best is, of course, to do a DLCO right at the beginning as well as after 2 cycles in case you expect it. And probably it's better to avoid in some patients where you don't want them to get bleomycin, like young, in our setup, especially the young soldiers, etc. You know, we want to get them back in the front to be in the arms. So we would try and avoid bleomycin beyond 2 cycles. If they have PET CR, we generally go on to AVD. But once bleomycin lung toxicity occurs, there was a view earlier saying that in case you use GCSF along with bleomycin, the lung toxicity increases. But that view is not very strongly taken right now. Specific treatment-wise, you can only avoid the drug. No specific treatment which I can recall. People have used nintedanib and other antifibrotic agents, but again, not much of data.
Yeah, one small bedside point is that, hyperbaric oxygen sometimes leads to more free radical base injury. So try to strike balance and give a bare minimum hypoxia covering oxygen only for those patients. In general, we are very liberal in giving oxygen. So that is one small bedside point one can use.
So any role of maintenance therapy in DLBL after our CHOP?
Yeah. So Gaurav.
Yeah, so maintenance trial, with very good amount of fanfare were initially tried, but they did not improve outcome of patient with DLBCL. I'm not recollecting correctly, but there was some subset in which there was benefit. But overall, currently there is no role of using rituximab maintenance for high-grade B-cell lymphoma. So you have a role for follicular, you have a clear role for mantle cell lymphoma. Now, in fact, mantle cell lymphoma, the role is so much so that we are putting off the transplant to a later date, which was a frontline. So therefore, like a triangle study, there are a couple of recent last year studies. So for either proactively follicular and these two mantle cell lymphoma is where clear role.
Yeah, exactly. We do not use the maintenance rituximab in DLBCL.
Yeah. So next is replacing obin with rituximab. I think this question comes up in CLL and FL backbone.
Yeah, this is a good question, and Faheema touched upon it actually. So the reason obinutuzumab Gazyva is there is showed benefit in CLL, but failed in Gazyva R-CHOP. Gazyva CHOP failed because in DLBCL CD20 expression is ample, is like full membranous strong positivity. So you have a lot of receptor. While CD20 expression in CLL patient is moderate, medium. So Gazyva has higher affinity for CD20, and therefore, in the trials, this is the hypothesis that it worked. Second thing is the mechanism of action. Rituximab mainly use complement-dependent cell cytotoxicity and ADCC also, but Gazyva is mainly ADCC and direct toxicity, less complement requirement. So these two changes are there, which may probably made it more effective in CLL patient than in DLBCL. And Dr. any point?
No, nothing.
Okay. Any other question?
I think there is one last question about how to differentiate pseudo progression from true progression on immunotherapy. How common it is?
Yeah. So on immunotherapy pseudoprogression, generally we find it somewhere around 9 to 12 weeks in that period where we find. So what we clinically practice is if there is a clinico-radiological dissonance where patient is improving, he's otherwise doing well, but the lesions are showing an increase or sometimes even one or two new lesions also. We do continue immunotherapy in these patients, expecting a pseudoprogression, but definitely the next scan is done by around next 8 weeks instead of waiting for another 12 weeks. So I think the best way to do is a clinico-radiological kind of a correlation and see if the patient is going down, scan is looking poor, the patient is progressing. So that's what we follow in clinical practice. And any inputs from Dr. Lingaraj and Gaurav?
Yeah, I think there is a criteria for that. It's called Lyric criteria. So they're
Lyric,
typically designed for immunotherapy related. You can look at that. One of them has asked how to remember the dose of EPOC, BCOP, and Precard.
I don't think we remember doses. Yeah, there's enough. How to remember doses is?
I strongly advise against remembering any dose.
Yeah, I don't think you need to remember doses at all.
Although initially when we were training, Dr. Tilak and we were together, so at that time, on a lighter note now, since we are concluding, we had that keypad phone, so therefore no access. Book आप नहीं रख सकते, याद करना पड़ता था. So at today's era, you guys blessed such a good access.
I think you're more likely to make mistakes if you try to remember and then try to put it. It's better to refer to a protocol, especially using more than 4 drugs.
Yeah, only CHOP and ABVD examiners ask in the exam also about that.
Yeah, you can
remember. Apart from that, whatever newer is,
yeah. So, and in fact, now more and more people are using hospital record system. Like I think Tata Memorial has already developed, and we are developing. printed protocol, every access of printer. I think most of us are trained in a handwritten era. Still we practice, but then so those you should know. But then like complex regimen, DA APOC one error and grade 4 neutropenia and patient may be in ICU. So therefore, for those complex regimen, like a SMILE regimen, like other conditioning regimen, at the back of our mind, we all know. Yeah, that is something.
That's it.
Karan had written that he wanted to answer some question. Karan, you want to come in and say something?
No, nothing, sir. I was just looking at the questions if everything is answered. Yes.
Okay. I think if the time is up, we can take concluding remark from Lingaraj and from Faheema also to come in.
So I can go first. So thank you, Tilak. So yes, is Faheema there? You can call Faheema
Yes,
also.
sir. Yes, sir. I'm here. I have been listening all. I'm sorry, I had a baby who might shout anytime, so I didn't.
Okay.
That's why.
Over to you, Faheema.
Yeah, it was so beautiful, sir. It was like my DM class again. So nice learning from the best of the best, Gaurav sir and Lingaraj sir, with such insightful inputs. Thanks a lot. I hope I did cover some whatever I could in the small molecules. And we hope to cover the rest with the incoming topics on myeloid neoplasms. And also, I think myeloma, we have a separate topic, right, Karan? Hello, Karan, are you there?
So, Karan is mute. I don't know.
No. I am right there. I'm right there. I probably couldn't hear. Sorry.
Okay.
Yes,
Yeah.
sir. I mean, thank you so much. I mean, we had a stellar faculty, and I think this is something which the students could, ask for. This was the best, and I think we had a really good discussion about the drugs, and I think the medical oncology side is a bit, lacking in the drugs which are in the hemat domain. But I think these sessions are really helpful, and I think in between the lines, which we don't get to read in Devita, these things are really helpful, and I must thank all of you again for sparing your time on a Sunday, and especially when the CAR-T session is going side by side. So thank you so much, sir. Thank you so much.
Yeah, and if it may be of help, all of you students might, contact me anytime via Twitter or text me if you have any doubts. See, I made a lot of slides and then I have to make them comprise because it has to be within 45 minutes. The notes are always available. Any doubts, I'm available for you all. You can contact me or ping me on Twitter anytime. Thank you. Thank you, sir. Thank you, Gaurav sir, Lingaraj sir, and Tilak sir.
Gaurav sir is also on Twitter, and he's pretty active.
Yeah.
Heads are really amazing. I mean, you should follow him.
Thank you, Dr. Karan, Dr. Faheema, and Dr. Lingaraj. It's a pleasure to be on the same stage with Dr. Gaurav as usual.
Thank you.
Thank you.
Just one disclaimer I wanted to tell that Dr. Ronak had to, fill in at the very last position. The other examiner had to go for the CAR-T quiz. So he filled up on the very last moment, and he's been very late for, preparing this whole thing.
He was such a sport. Kudos, Ronak.
Thank you, Ronak. Thank you so much. And thank you, Atul, again.
Thank you, guys. Bye-bye.
I'll take this time again for all of you to join next week on 20th April. So our next session is on newer drugs. We'll be talking about tumor agnostics. We'll be talking about newer drugs in breast, lung. So do join in. We have one of the most famous oncologist who is regularly tweeting about most of the newer drugs. That is Dr. Amol Akhade, sir. And we'll also have our moderator as Dr. Safalta. Our mentor is Dr. Hemant, sir. And our speaker is young, dynamic, Dr. Akhil Santosh from AIMS. So we are looking forward to that session. Please, all of you do join. And thank you. We'll end the session here.
Karan, what is the topic of this one?
Sir, this is newer drugs.
In general?
In general, mostly solid oncology.
Solid tumor, mainly solid.
Solid tumor, yes.
Thank you. Bye-bye.
Bye.
Bye, sir. Bye, sir.
Bye.